Hey, thank you, Donna, for the introduction, and thank you for the invitation to speak here today. Basically, what I'd like to talk about is successful Aboriginal health interventions and how we can establish effective cross-cultural communication. So, disclaimer, the views expressed here are my own and don't reflect my employer. It's necessary evil. So, why is there such a hoo-ha about Aboriginal health? We all know the statistics, but the one that really hammered it home for me is this graph. Shows the proportion of deaths by age group and Indigenous status. The darker grey bars are the Indigenous, lighter grey non-Indigenous, and it shows that 75% of Indigenous males and 65% of Indigenous females died before the age of 65, compared to non-Indigenous, 26% of males and 16% of females. So in this talk, I'd like to briefly discuss the literature review, which I did, and how it relates to the learning objective below, which I'll be going through, and how my work with Aboriginal youth in rural and remote WA also developed my understanding of that literature, of that learning objective rather. And I'll discuss how it relates to public health and how it's affected my daily practice as a junior doctor. So to start off with any good literature review, I did a systematic search. So searched PubMed, Medline, the Cochrane database, Google Scholar, conference proceedings. Unfortunately, there wasn't really much out there. There was limited high quality evidence, and what was there was really not very statistically rigorous. There were some government reviews and position papers, but in the end, I ended up doing more of a qualitative analysis, more of a phenomenological study, if anything. And I found several common qualities among successful Aboriginal health interventions. But these qualities also related to the learning objective, which is establish effective cross-cultural partnerships to achieve improved public health outcomes. And I'll go through each of the elements of competency in turn. So with regards to the first element, it's understanding culture as a determinant of health. So what is culture? The ideas, customs and social behaviour of a particular people or society. But importantly, the Aboriginal definition of health is much broader than that and encompasses really the social, emotional, spiritual and cultural well-being of the whole community. And importantly, Aboriginal culture is also viewed as a source of resilience and provides a way to improve health. So in my lit review, I identified an intervention which successfully utilised this link to achieve improved public health outcomes, and that was the Jury Community Sports Massage Program. In this program, the Jury community identified there was a high prevalence of musculoskeletal problems. So they asked a researcher from the University of Newcastle came down, worked with the community and a physiotherapist, and they developed a program which incorporated both Western medicine and traditional bush medicine. And this ended up being accredited nationally. And the Aboriginal elders remarked that they strongly endorsed this collaborative approach, which affirmed their traditional methods of healing and the Western, accredited course of study. And it's an example of how you can incorporate traditional culture into a health intervention to achieve improved outcomes. The second element relates to recognising how our policies and practices as a dominant culture influence the health of other groups. So this, at broad face, is sort of a obvious statement, but I think it's still ongoing, so things such as the Northern Territory Emergency Response Act, and I'll go into this later on about why I think that it might not have been effective as it could have otherwise been. And in my lit review, I just emphasise that we should form policies and interventions which really emphasise the autonomy and self-determination of Aboriginal people, as well as the importance of collaboration and integrating existing community knowledge. With regards to the third element, identifying the values and needs of the cultural groups, unfortunately it seemed to me from what I did in lit review that it's often not really well achieved in health interventions that we're carrying out now. Aboriginal healthcare requires a holistic approach as evidenced by the definition there. However, a intervention which did do a good job of it actually was the Willora Community Nutritional Program. So they had an existing meal service in the community to cater for old people. So the station would provide old people with uncooked vegetable and meat. What happened was they couldn't cook the meat because they didn't have the ability they couldn't cook the vegetables because they didn't have the ability or equipment. So the meat portion would just get cooked and everything else would get left uncooked. So the women in the community recognised this, and they contacted the remote area nurse, who then went on to contact the nutritionist who came to the community, consulted with all the relevant parties, and a multi-step process was initiated which led to the local community facilities being improved, local grants being obtained, a paid position being made so the local women could cook for the elderly people, And it basically led to the local women being empowered. They were more able to advocate for their own needs, and it led to improvement in the health of the local community. So it just shows that if you identify the values and needs of your group, how much more exponentially effective your intervention can really be. And with regards to the fourth element, it refers to using appropriate sources of information when working with other cultural groups. And in my lit review, you can see there's a large range of sources which good, successful interventions utilised. And again, the importance of collaboration. So I was involved in a project called Dr. Yes, which stands for Youth Education Sessions. And it's a group of medical students, that's us there, who go to secondary schools across WA and discuss alcohol and drugs, mental health and sexual health. And I guess the question is, how did I integrate the knowledge which I gained from our lit review with the program? So with regards to the first element, when we go to local metropolitan schools, our definition of health and disease is quite Western, but when we go to those schools, we incorporate spiritual, sort of community cultural aspects as well, and we incorporate Western and bush medicine and talk about them as more complementary therapies, and that's more relevant with mental health as well. With regards to the second element, we recognise that as the sort of foreign, people coming into the community, we had a great power to do good and bad at the same time. So it was up to us to make sure that we identify the values and needs and make sure we address them, which brings me on to point 3. So we would talk to the principals of the schools we went to and make sure that our program addressed what they wanted, modified our program if need be, and we visited the local Aboriginal medical services and made sure we were aware of what they were offering and made sure what we were offering was culturally appropriate. An example of something we changed was that one of the remote communities actually had a recent suicide. So we modified parts of our program, took bits out and made it more culturally appropriate for them. And again, we used the appropriate individuals and organisations, as I previously mentioned, and we invited local people like doctors and nurses to come to the sessions and to sort of show their face and be known to the students. We could have done a few things better though in hindsight. I don't have the time to go through them in full detail unfortunately, but they relate to having a longer time frame and following up our visits and talking to the Aboriginal medical services for a long time before we came, because in this visit we only talked to them the day before we visited the students, so it would have been good to talk to them beforehand. So what are the practical policy implications of what I've just discussed? So I guess the overarching thing is really we should be emphasising the autonomy and self-determination of Aboriginal people, calls for a grassroots approach and a holistic approach really, which integrates the existing community knowledge. And the interventions should be well designed with rigorous evaluation pre and post, something which was missing from most of the studies which I looked at in my lit review, and the project should be sustainable. But how are we doing nowadays? Well, I discussed the Northern Territory emergency response. It was in response to a 2007 report into sexual abuse into Aboriginal children, and it brought in blanket changes in policing, alcohol restrictions, land ownership, welfare, and other measures such as how people could use their welfare payments, and was recently extended for another 10 years. It's had mixed results. It's had some good results. It led to a 17% decrease in mortality rate from 07 to 011, but in more than doubling incidence of self-harm from 107 to 229 over the same period. If we look at the elements of competency for the learning objective, did they understand culture as a determinant of health? Well, it doesn't really appear that they did. So the 2007 bill, which extended it, had 5 sections. Introduction, 5 pages, tackling alcohol abuse, 30 pages, land reform, 5 pages, food security, 20, and other matters, 1. There was no mention anywhere there about cultural factors. It was quite a narrow, targeted intervention. So I think that they probably could have done a slightly better job at taking a holistic view, which has been shown to work better when designing interventions. Point 2, they probably did recognise, I guess, to some extent how they could influence their health, but they didn't really sort of liaise with the communities and talk about what they needed, which was one of the main sort of criticisms of the intervention. And they didn't really seem to identify the values and needs because they didn't, again, take that holistic approach and identify what they needed. And interestingly enough, some of the Aboriginal organisations in the literature said that they might have supported the measures had they been undertaken in a different way. And this quote's a really good quote. It just illustrates why broad-based interventions don't work. It's from Patricia Morton-Thomas, who's in the Redfern now, and it just shows that you can't apply the same thing to everyone because it won't work. The interesting thing is there's been a call from WA Aboriginal activists calling for some similar measures to what's been implemented in the NT. I'll just point out the important bit down here. So he wants to reward or penalise residents based on whether they meet certain responsibilities, such as school attendance and paying rent. I guess it's not really in contradiction to what I was talking about before, because this approach is grassroots-led. It emphasises the autonomy of Aboriginal population and it encourages self-determination, basically. And just a quick word about the recent budget. Has some pros and negatives for the Aboriginal people, but time will tell whether it's an overall good or bad thing. So how did this impact on my daily practice? I guess a small bit goes a long way for all of us. When I talk to my patients, I try and talk about traditional healing practices and see how they can integrate it into their medical treatment. Again, I try and talk about it as complementary. Talk about their family ties. It often helps patients because they're quite, kinship systems are quite important. So having their family there or being able to talk to them is quite helpful for them. Allocating extra time to discuss history, diagnosis, prognosis, because they often don't give typical Western histories, and you need more time to talk about their symptoms and what they think it's related to, and also explaining the diagnosis and what it means. And you can give them, pamphlets which are ATSI friendly, low threshold for involving the Aboriginal health worker. And I'm able to, I think, relate to my patients better, and importantly advocate on their behalf as a doctor, which I think is quite important. So in conclusion, the learning objective which I've identified is establish effective cross-cultural partnerships to achieve improved public health outcomes. I've done that through my literature review and my work with Dr. Yes, and I've provided a public health perspective and shown how it's really impacted on my daily practice as an intern. And I guess it'd be interesting to see where we are in 10 years' time. Thank you very much.
Yeah, so I'm glad you're all standing up and putting into action what we've just learnt. Any questions for Siaavash?
Thank you, Siaavash. I just was wondering about your literature review, and if you only looked at Aboriginal populations or whether you looked at Indigenous populations around the world, and whether you see any similarities.
Yeah, so at the start, I did catch a lot of sort of Canadian literature. There was, quite similar things as you'd expect, in the importance of autonomy, self-determination, that sort of thing. So it appears that it's a common theme worldwide that you can't have a paternalistic sort of top-down approach. It has to be grassroots.
Thank you very much indeed. A couple of talks tonight have actually picked up on communication skills and the importance of communication skills. And once again, I just take the opportunity to ask you to reflect about how did your, you've done this great piece of work which has helped you to develop your own skills and reflect upon them. But how did you, how was that developed during your time in medical school, and what do you think they could have done better?
It's a difficult question because I think not enough emphasis is placed on Aboriginal communication skills to begin with. As one of the other speakers said, you get it as a once-off sort of dose in the first, second, third year where it's not really that useful. So I think it should be an ongoing sort of thing. But I think more importantly, it should be the most important experiences I've got are from talking to Aboriginal people. You can only learn so much from dot points and lectures, and it's been through talking about the experiences which they've had, going to Dr. Yes, going to communities, seeing how they live. That's really opened my eyes and let me be able to relate to them better. Like, I've been to Halls Creek, I know what the alcohol situation's like, I know what the family situations can be like. So I guess obviously all medical students can't go there, but I think it's important that they be exposed to that sort of Aboriginal lifestyle, whether it's visiting Aboriginal more visiting Aboriginal lecturers, whether it's videos, just anything that will really give you more visual or hands-on experience. I'll
just follow that on, because it is a challenge, isn't it? Because there's hundreds, thousands of medical students these days. I think there's 22 medical schools, isn't there, Donna, around the country, and literally thousands of medical students. So the question is, how do you provide people with what you're describing is not so much meaningful, that's a fairly sort of paternalistic word to use in itself, but the kinds of learning opportunities that involve Aboriginal people without actually exhausting what would probably be around any medical school a reasonably discrete population of Aboriginal people. I think it's a really interesting challenge, actually. I think it's one we have a long way to go before we address. But if you've got any ideas, you've just been through it, so you've probably got a consumer's view.
Yeah, so I agree. It's a really difficult question. It comes down to, money as well, whether schools are willing to spend the money to send out all the students to, rural communities, that sort of thing. But again, I think it's just having the exposure to Aboriginal people, exposing them at an early stage, that sort of Indigenous culture, so they can relate their lectures to that. Fortunately, through Dr. Yes, I was able to visit those schools throughout my medical student career, so I was able to relate the lectures back to that, but not all students have that opportunity. But maybe it's a case of expanding Dr. Yes, which is an AMA initiative, to other med schools. It's only in WA and Tasmania, I think, was trialling it. So the answer could be having more of those sort of student-led programs which really expose the students to that sort of lifestyle.
Terrific, thank you.
Thank you.